Good morning, and welcome to our first session of the day, Types of Facial Pain. I am Brandy Underwood, the FPA's Manager of Marketing and Communications, and I am happy to welcome Dr. Michael Lim, Professor and Chair of the Department of Neurosurgery at Stanford University School of Medicine, and a board-certified neurosurgeon specializing in brain tumors and trigeminal neuralgia. He is also a member of the FPA's Medical Advisory Board. Welcome, Dr. Lim, and thank you for joining us today. Before we get started, I'll ask that attendees submit questions using the Q&A feature on your screen. We'll get to as many questions as we can after the talk. And now I'll turn it over to you, Dr. Lim.
Thank you, Ms. Underwood. So it's a privilege and honor to be here today. So I'm going to share my slides. Ms. Underwood, do you mind just confirming that you can see them?
Yes, we are able to see them. Thank you, Dr. Lim.
Okay. So good morning. It's an honor and privilege to be here to speak with you today. As you can see through the program, we're going to be talking a lot about different types of facial pain. And I think a lot of the day is going to be dedicated to trigeminal neuralgia. And so I was asked to speak a little bit about facial pain other than trigeminal neuralgia, because as we all know, there's many different types of facial pain. And so what I thought I'd do is to kind of just start us at a baseline of just a brief overview of trigeminal neuralgia in terms of what the symptoms are. And then as I've gone through about and thought about the different types of facial pain that we could talk about today, the list is exhaustive. And so I tried to group them into three categories. One, what I call other types of neuralgias. And then the second part is some other common types of pains that sometimes people come to see us with that is not trigeminal neuralgia, but has been classified as trigeminal neuralgia by the referring doctor. And then kind of, I think what I call a big picture strategy of what's relevant to our patients. So I think most of us know about trigeminal neuralgia in this room. We know that it's a condition, it's a clinical condition. There's no blood tests or MRIs or CAT scans that one can give to make this diagnosis, yet it's made by purely by symptoms. Patients usually say that they have sharp stabbing pain or electrical pain that's triggered by some sort of sensory stimuli or stress, for example, eating, drinking, or cold wind. And it's usually on one side of the face. And it is the most common cause of facial pain in the US or throughout the world. And what's interesting about it is even though it's the most common, it's relatively rare. Just to give you a reference, glioblastomas, which is I'm sure many of you heard about, a very malignant brain tumor. There's only about 13 to 15,000 cases diagnosed per year. And so trigeminal neuralgia is also kind of on the rare side, 15,000 cases per year. But unlike glioblastoma, which is a very aggressive disease and people may not survive more than a year or two, people do not die from this disease. And so if you can imagine 15,000 cases every year for 30 years, it's about 500,000 people in the US at any given time has trigeminal. It occurs a little bit more frequently in women than men, and the onset is usually from patients in their 40s to 60s. So when I see patients in my clinics, sometimes they come with other types of neuralgias. And so what I thought we could talk about today as we talk about other types of facial pain is some of the other neuralgias such as geniculate neuralgia and glossopharyngeal neuralgia. So I wanted to start with geniculate neuralgia. Again, this is even rarer than trigeminal neuralgia, but there's a very characteristic location that this pain arises in. And it's people usually almost come into my clinic and have their finger in their ear, telling me exactly where it is, because it's deep in the ear. It's not around the ear, it's not in front of the ear, it's not on top of the ear, but it's deep in the ear canal. And people often say it's sharp stabbing. Some people say it's like a spike that goes into their ear and then the spike opens up. It's extremely debilitating. And the cause of this is still unknown. And when you make a diagnosis, again, it's made on a clinical diagnosis. It's made clinically. Again, there's no blood tests or imaging that can help us with that diagnosis. But a lot of patients do get imaging, and it's important to do that because we have to rule out other things, such as tumors in that area that could cause this pain. Now, some people with this type of pain can get some relief with some of the traditional meds, and you'll hear about them today, the carbamazepine, the Tegratols, or Lyrica, or gabapentin. But in a subset of patients, there's no relief with this medication, where they become tolerant to this medication. And so when people come to see us, I put in the word, it's not a decompression, but I'll talk about this. The operation that's usually done is something very similar to microvascular decompression. But the nerve that we're targeting is something called nervus intermedius. It's not the trigeminal nerve. Now, some people believe it's that compression is the cause, and there are reports of compression being the cause of trigeminal neuralgia. But in my experience, decompressing the nerve has been more disappointing, and actually cutting or sectioning the nervus intermedius usually is the treatment. And again, nervus intermedius is a sensory nerve. And patients say to me, well, what's the sequelae, or what am I going to lose if you cut that nerve? It seems like God gave us that nerve for a reason. And I tell people it's a sensory nerve in the deep part of the ear. And when you cut that nerve, people you really don't notice anything different. You'll be able to carry out your daily life. I take out large brain tumors such as acoustic neuromas, or they call them vestibular schwannomas, and oftentimes the nervus intermedius is cut in that procedure, and patients don't feel a difference. Now, what I thought I'd do is I'd just show you a picture of this. The nervus intermedius is a very tiny nerve. You'll see Roman numeral 7 and 8. The nerve is split apart, but it's actually one cable. And you can actually see the 8th nerve and the 7th nerve in the operating room, and you have to gently tease them apart to find this nervus intermedius. And so the 8th nerve is responsible for hearing and balance, in essence, and the 7th nerve is responsible for facial movement. And again, this is a sensory nerve, and that's what we usually try to cut. Now, there is, again, two schools of thought that are out there. Some section the nervus intermedius, and you can see the little nerve sticking out here that we cut. And some try to put a little Teflon pledget, thinking that that's the cause. Now, in my experience, I found that putting the cushion there has been disappointing. I have a video here of sectioning the nervus intermedius. And as I mentioned before, so here we are cutting the nervus intermedius. As you can see, I've been able to separate and tease it. But I originally tried decompressing the nerve. And if you look here to the left, you can actually see the Teflon pledget. This person had trigeminal and geniculate neuralgia. And so I had decompressed both areas at the time. And unfortunately, when I decompressed, the patient didn't feel any better, and I had to come back and section nervus intermedius. And the patient woke up immediately with no pain, and they were thrilled. I also wanted to show again another video of us actually of how we find nervus intermedius. And this is relevance to of how we of some of the complications that happen. So what we're doing is I'm gently teasing apart, pulling the 8th nerve, and then you can see the 7th nerve as I'm separating it down there. 7th nerve is responsible for face movement. And again, you can see a little artery that's compressing it. And as I separate the two, you'll see a tiny little strand come out. And when you see the tiny strand, it's right there. I don't know if you could see my mouse. We're able to separate it out. We can then come in and then snip it. And what I do is after we identify that nerve, we literally go in and snip the nerve. And there you are. We lift it up and we cut it. And that's the surgery. So what are the risks of this procedure? So one of the one of the significant risks is, as you can see, you have to tease apart that eighth nerve to get to that nervus intermedius. And so in some patients, there's a risk of hearing loss. And what we do in surgery is we monitor the hearing, but you can still have hearing loss, and it's a small risk. And so what's interesting is I've had a couple patients come to me, and usually I will stop if I start to sense a certain amount of, if I think the patient's going to lose hearing. The pain is so bad in some patients, they say, I'm willing to take the hearing loss for getting relief. And so it just, again, highlights how bad this pain it can be. Also in that nerve is the nerve responsible for conducting what we call balance, the balance center. And so some patients wake up with vertigo. They feel massive amounts of vertigo. But I have to say, I have rarely seen that be permanent in anyone. It's almost 99% of those patients always get better. Because we're also near the facial nerve, some people can wake up with face nerve weakness. I have not seen that, but in theory it could happen. And then there's also a very small nerve that runs, that could run right next to it or in it. It's called chorda tympani. And that is the nerve that's responsible for taste and smell. So I have seen some patients have altered taste from this procedure. It's extremely rare. It's probably under 1%. And then just like in MVD, people can have CSF leaks, but that's, again, very rare. The second neuralgia I want to talk about is something called glossopharyngeal neuralgia. Now, again, remember, trigeminal neuralgia is in the face, geniculate neuralgia is in the ear, glossopharyngeal neuralgia is actually deep in the throat. And it's sharp stabbing pain in the back of the throat. It's triggered by, again, eating or drinking. Some of my patients say they feel like they're swallowing glass shards. That's how uncomfortable the pain is. And it's usually because, again, there's a compression around cranial nerves 9, 10, 11. 9, 10, 11 is essentially one bundle, but it's really the ninth nerve that is responsible for transmitting the pain. And it's usually caused by compression by an artery. But what I have also found is that some of my patients that I've done the surgery have not really found an artery, but very dense adhesions. It's almost like a matting of the nerve. And when I go in there and I really clean out that area and release all the matting, I've had some really great results with that. So when I do the imaging to rule out other things, if I don't see a blood vessel, I still, in some cases, have offered the procedure, because just clearing all the scar tissue around that nerve has really made people feel better. Like trigeminal neuralgia and geniculate neuralgia, it's a clinical diagnosis. As I mentioned before, imaging is used to rule out other causes. And treatment, first-line treatment is medications. And if the medications fail the patients, it's a microvascular decompression. Now, I wanted to show a cartoon picture just because it's sometimes a little bit harder to see. The 9 is the top nerve. It's a smaller nerve. 10 is the what they call the vagus nerve, and 11 is it looks like the little strands that go below. And this tiny strand is usually the part that causes pain in patients. And the whole idea is to put a cushion between the artery and the nerve. I do a fair number of them, but I couldn't pull up the picture for some reason. So I was able to get this picture from the Neurosurgery Atlas, which is very typical. In this picture, you can see to the very right, the strand is the 9th nerve, and then the 10th nerve is to the left. And you can see an artery abutting the 9th nerve. And so what you can do is you can go in there and you can decompress the nerve, and you can see some nice Teflon pledgets in there cushioning the nerve. And so the risks of this procedure, the 9, 10, 11 nerves are responsible for speech and swallowing. And if it's manipulated or it's damaged, there's a risk of having speech problems. You could have a hoarse voice or paralyzed vocal cord, or you could have problems with swallowing where you could choke on even drinking water. So again, maintaining those nerves is incredibly important. And as I mentioned before, as I've taken out lots of tumors in that area, I've seen those nerves stretched really thin by big tumors. And so these nerves are pretty hardy, but it's still a risk. Also down there is the nerve for tongue weakness, which is a little bit south of those nerves. And that's, in theory, also a risk. I have not seen that. It's very rare. The 11th nerve is also responsible for having you shrug your shoulders. But again, those are very rare complications. And again, the CSF leak risk is very low. So the next class of tumors that I thought that, again, we could address, that can be addressed surgically for patients who come in with pain, is actually pain caused by tumors. I always get imaging on my patients before I do surgery because in a small subset of patients, as I mentioned before, the imaging is used to rule out other causes, and you can actually have tumors that cause pain. And so here's an example of what we call a meningioma that's compressing the 5th nerve here. And this person was, again, presenting with stabbing pains in their face. This is another type of tumors called a schwannoma. And what's interesting is there's a tumor in the back that's compressing the trigeminal nerve, but it's running along the entire trigeminal nerve into something called the cavernous sinus. But the reason for this is in the back here, I don't know if you can see my mouse, the one next to the brainstem requires an MVD approach. The one that's up in front of the brainstem is a different compartment in the brain and requires a different surgery altogether. And so what I learned earlier on is I used to try to go for the bigger tumor because I assumed the bigger portion of the tumor because that's where I assumed the pain was coming from. And when I did that, and the small tumor was still behind, the patient still had pain. And it wasn't until I removed this posterior or the back portion that patients actually felt better. And again, you can see this is a tumor that tracks a little bit forward. It's the back part of the tumor. In almost every case I've taken care of, that's the cause of pain in my patients. And so with these benign tumors, I've had really much larger, tumors that look disproportionately larger in the front than in the back. Almost always, if quality of life is the issue, addressing the tumor in the back is going to help the patients. Now, I wanted to show that in this situation, this patient had their trigeminal nerve squished, as you can see up here in the front. I don't know if you can see my mouse. And after I removed it, you can see the trigeminal nerve hanging freely. And in general, removing the tumor will address people's pain. And I've had we've had a lot of success in helping patients with that. What's interesting is if you can get a definitive resection, regardless of the pain being sharp or stabbing or burning or aching or throbbing, if you can get a definitive resection, you can maintain the integrity of the nerve, the pain usually is addressed. However, sometimes these tumors don't behave and they invade into the trigeminal nerve. And even though we can gently peel the tumor off the nerve, if the tumor is invaded into the nerve, patients can actually wake up with additional pain and or numbness. And so sometimes when these tumors come out, I counsel my patients saying that they could be left with additional pain or numbness. And the pain is usually not sharp and stabbing in nature, but it's burning in nature. And also the nerve that's responsible for chewing is right next to it. And some patients can have chewing weakness. So it's important that we study the films very carefully and we counsel our patients. So there are situations where patients come in and tumor removal is not an option. In some of my older patients, I've had patients in their 80s and 90s who present with a meningioma, and it's not something large enough where it's compressing the brainstem, and they are on blood thinners, or they can't be off blood thinners for a long time. There are still options to help patients with pain, and the nuance to this is that it has to be sharp stabbing pain for patients if we want to be able to help them surgically. If they have burning, aching, or pressure type of pain, generally I encourage them to seek medical treatments, but sharp stabbing electrical pain the patients actually have a pretty good surgical options. And I usually offer a rhizotomy. Now, I have seen patients get radiosurgery for this, and in general, my experience, and I'll let my other colleagues on the calls too weigh in, but I generally do not like radiosurgery for patients. And the reason for that is that the dose of radiation that you use to kill the tumor is about 14 grades. And then the dose of radiation you need to treat trigeminal neuralgia is 70 gray. It's about 5 times higher. And so the lower dose actually irritates the nerve, and I've actually seen people come back with much worse pain. So as I mentioned before, a rhizotomy is this procedure where you can actually inject or put a large needle right next to the lip and put it at the bottom of the skull to basically inject glycerin or burn the nerve. And what I've done is I've actually treated patients with glycerin rhizotomy. And this is an experience. We haven't published this yet, but it's being submitted. We've treated about 23 patients with either meningiomas or schwannomas, some of these benign tumors. And a lot of them have had actually sharp stabbing pain. And when we treated them with rhizotomies, actually you can see that their pain scores improved. And you can see the blue here after. It's pretty dramatic. We can really get some nice relief. The biggest complications that I've had are some numbness. Very rarely have I had burning pain. And in those patients that have had burning pain, it's usually happened in delayed fashion. And actually their tumors were growing to change the characteristic of the pain. But I usually just do glycerin, and it works very well. As I mentioned before, the dose of radiation to treat, if you use gamma knife or cyber knife, is 14 to 18 gray. The dose of radiation to treat that trigeminal neuralgia is 75 gray. I've been burned several times by trying to treat patients with radiosurgery. So as I said before, I usually recommend radiosurgery. So I just want to briefly touch on other types of pain that you'll hear about today. There are other neurologists and pain specialists that are on the call that were last night and today. But for example, there's herpes zoster, TMJ. We have a great talk coming up later. There's problems with the orbit or inflammatory conditions or tumors that can again cause these types of pain. So when I see a patient that comes to see me, when I see a patient in clinic, I usually say to patients, there's 2 things you want to accomplish with your visit, right? When you see somebody for pain. One, you want to know what the cause of your pain is. And the second thing you want to understand is there something that they can offer you to help alleviate the pain? And your conversation should revolve around both of them. Many times, as I've alluded before, we don't often know the cause of the pain, but that means that you have to have a doctor that you see routinely so that you get routine follow-ups. Because sometimes over time, I've seen a small tumor that was basically so subtle you didn't see it until years later. And I've seen people develop, for example, autoimmune conditions and MS. And so again, getting routine checkups is important. And then alleviating the pain. And when they come to see me in clinic, there are certain things I can offer and certain things that I cannot. And sometimes surgical procedures can worsen the pain. And so from a more practical standpoint, when oftentimes you see some of the neurosurgeons here in clinic, we kind of say, do you have typical trigeminal neuralgia, which is what I talked about earlier, the sharp stabbing, or do you have what's called atypical facial pain? Sometimes they call it type 2. Sorry for the typo. But with type 2 pain, it's generally pain that's not the sharp stabbing electrical pain. It can be the burning, aching, throbbing, constant. What I've seen a lot in my clinic is that it's been associated with some of these inflammatory conditions, rheumatoid arthritis, lupus. But when people come with atypical facial pains, we find that some of the traditional trigeminal neuralgia surgeries that we offer, the MVDs, the rhizotomies, have been actually very disappointing. And we encourage patients to work with the pain doctors because oftentimes these medications can do better. But there are other things, and I have 2 functional neurosurgeons, Vivek Butch and Ashwin Ramaya, who are coming to Stanford, who've really been taken interest in atypical facial pain, and they've done caudalis DRES, stimulators, and deep brain stimulators. Even the motor cortex stimulators have had case reports of working. But in general, the typical trigeminal neuralgia surgeries don't work. And then there's something called the mixed typical and atypical facial pain. And these are patients who come to me having both elements of sharp stabbing, or come to any of us with sharp stabbing, and what we call atypical facial pain, maybe an element of burning or throbbing or aching. And this is what I think, this is something that I think should be very personalized. And I'm sorry the light turned off here, but hopefully you can see me. Is personalized. And I spend a lot of time with the patients trying to understand. If the patients say to me, 90% of my pain is sharp stabbing, and if you can get rid of that, my life will be much better. I had this question of saying, well, how can we help these patients who have a mixture of typical and atypical, but feel that if we can address the component of the pain, i.e. the typical pain, would it make their life better? So we looked back at some of my patients, and we had a study that we published in World Neurosurgery. We looked at 74 patients who came in with the mixed symptoms, and all of those 74 said to me, if you can make the sharp stabbing pain go away, you'll improve my quality of life. And what was interesting is when we did, and these all received a microvascular decompressions, about 72% of the patients had immediate pain relief. And it was both atypical and typical. And I usually told those patients, the atypical is probably more from the anesthetic than the MVD. But actually, some of those patients had durable relief, to my surprise, as I followed them. And this, I didn't finish that, but 19.7% of those patients did have actually immediate relief of specifically more on the atypical side. And when we followed those patients out a year, about 30% of the patients had recurrence of the sharp stabbing, and 30% of the patients actually had a recurrence of the atypical facial pain. So it's been my philosophy to actually offer microvascular decompressions to patients with mixed symptoms. Lastly, I just want to comment on a couple things that I see commonly in my clinic that have non-typical TN pain. Migraines are something that I really have grown to appreciate that can be really complex. We always hear about migraines as someone coming in with an aura and then really bad headaches. It affects a lot of the population, 13% of the population. But there are several variants, and right now they say there are 3 variants, but there are probably more than that. And amongst those variants, there are some patients who can present with what they call sensory motor or visual auras, and a pain originating around the brain stem. And related to it is something called cluster headaches and SUNC syndrome of neuralgia formed conjunctival injection and tearing. Basically, they present with facial pain with tearing and red eyes. And I spend some time in the clinic trying to understand. And if they have these conditions, they're actually very good treatments. And I remember having a patient that came in with burning facial pain, and we sent them and they got a CGRP antagonist, and they did really well from that. And then herpetic neuralgia was one nuanced disease that I didn't offer surgery to. But it's basically shingles in your face. And in some patients, it's usually a very self-limited thing. Once the shingles resolve, your pain goes away. But in some patients, they can actually have residual damage to the nerve, and they have burning pain in their face. And people have tried medications, antivirals or epileptics. But then there was a series that was published, and I apologize for not having it here, where people offered rhizotomies for patients with herpetic neuralgias. And I was a little bit dubious on it, but I've had a couple patients that really had no other options, and I've offered them. And I can tell you, I've just offered them selectively, but rhizotomies have helped some of those patients. And then lastly, I want to talk about anesthesia dolorosa. Anesthesia dolorosa is something that I'm sure many of you read about on the internet. It's literally painful numbness. They call it a deafferentation pain. It's usually nerve injury. It could be something from a root canal. It could be something from plastic surgery. And it's just a constant aching, burning pain. And it really affects people's quality of lives. Many people actually even have depression that arises from it. And people have tried medications, anticonvulsants, narcotics, and even ketamine for this to try to get patients pain relief. And unfortunately,
One sec.
Trigeminal neuralgia doesn't, I mean, the MVDs don't work for this. But we have dedicated functional neurosurgeons at Stanford and across the country. And Vivek Butch has actually been really interested here at Stanford about that. And he just treated somebody recently with anesthesia dolorosa with some of these stimulators, and has really been able to help people. But it's a really tough condition. And I have to say, with with rhizotomies and with gamma knife, we run a small risk of causing anesthesia dolorosa in my patients. So I'm usually very conservative when I start because I worry about this for patients. So I kind of gave you a tour of the other types of facial pain. And actually, I've only scratched the surface. There's a lot of other causes, and we don't even know yet in 2023 all the causes. But as you can appreciate, these diagnoses I made clinically, which suggests that there's probably a spectrum. The way I see it is kind of, there's the way pain arises, and I think it very simplistically is, you can have pain that's electrical in nature. I call it almost like a seizure of the nerve, like it's, and that's usually like the trigeminal neuralgia, sharp stabbing pain, and usually that's why, for example, MVDs, rhizotomies work. And then you have pain that's caused by what I think is scar or damage to the nerve, which causes constant aching pain. And you have to have different strategies to treat them. And so when you go and you talk to a clinician to try to help you with your facial pain, it should be really revolved around two things. What is the cause of my facial pain? And what can be done to help alleviate facial pain? And when we as clinicians evaluate you in the clinic, one of the major decision trees, and I think you hear all of us ask you, is tell us about the character of the pain. Sharp stabbing pain versus burning pain is a major decision tree on which path to go down for recommending treatments. And as you saw last night in the for example, with Dr. Barad and Dr. Chang, treatment for you should be multidisciplinary. What I've appreciated over time is pain is not static. It can change in intensity, frequency, and character over time. I've seen patients who have burning pain and then 3 years later come with all sharp stabbing pain. The causes for the pain can be multifactorial, which is again why it's so important to have a multidisciplinary team. Oftentimes I have a rheumatologist that I call because if I'm suspect inflammatory disease. And these can be associated with other diseases. And that's why imaging is done, to try to rule out other causes. So I just want to acknowledge that I get to work with a great group of people. When I arrived to Stanford, I really wanted to try to create a complete facial pain center. That's why you met, for example, Dr. Barad. I don't think Dr. Kian was on the call, and Dr. Salmasi at Stanford. You met my partner, Dr. Chang, as well as my other neurosurgeons. Jamie Henderson, Vivek Butch, and Ashwin Ramaya do the functional in our department, and then our radiation oncologists and our clinical trials division, as we have some clinical trials for patients with facial pain going on. And as you may have known, I used to work at Hopkins, and I still have some very great collaborators there who I work with there. So thank you for your time, and it's my contact information. Happy to answer any questions.
Thank you, Dr. Lim. That was an excellent presentation, and we have several questions, as well as many comments thanking you for patients you have treated in the past who are now experiencing pain relief. So I wanted to share that with you at this time as well.
Thank you. Well, it's been my honor to be here, and it's been my honor to take care of a lot of the people who are on this call. So it's our dedication. Everyone on this call is really dedicated to helping our patients here.
Absolutely.
I'm sorry that my light went out. So
no, that's okay. That's okay. One of the things of having a live conference, right?
Yeah. Last time my daughter came onto the call, so it's always something.
Oh, it's sweet. So let me jump into the first question. And I've seen this shared several times. People want to know, is it common for patients to have multiple types of neuralgias? So diagnosed with trigeminal neuralgia and then possibly, glossopharyngeal or geniculate or even occipital neuralgia.
Yeah, so absolutely. I've seen patients come with with multiple neuralgias. And in fact, it's not uncommon for me to have a patient where I might section nervus intermedius and do trigeminal neuralgia. In fact, in one of the videos, you saw that. And I've seen people come with all three. And when I see patients with multiple neuralgias, the first conversation I have, again, revolves around two things. What is the cause of the pain? And can we help you get relief? My belief is that when you have multiple neuralgias, there's probably something more systemic going on in you or in that patient. So we have to, they have to make sure that they get routine follow-up with their neurologist. Because if you go to a house, the analogy I always use, if you go to a house and, for example, we address the dining room, and the dining room and the kitchen and the bathroom lights are all flickering, it's probably something at the circuit breaker or the power line coming into the house. It's important to check that, but we can still get you pain relief, which is that second element, which is if we can help you with decompressions or sectioning nervus intermedius, we've been successful in helping people.
Thank you so much for answering that question. During your talk, during your presentation, you touched on kind of Sunct and Suna and other trigeminal autonomic cephalias. And I have a question from the audience I'm going to share here from Anna Williams. She's asking, can you describe the differences between trigeminal neuralgia in the first branch and Sunct or Suna, which are TACs?
Yeah, so a lot of times they're called, Sunct is when you have facial pain similar in that area as trigeminal neuralgia in the V1 near the eye, but they present with what we call autonomic, oftentimes some tearing or red eyes, right? That doesn't happen with trigeminal neuralgia. And so it suggests that it's not a typical trigeminal neuralgia case. And so with those, again, I have had people with Sunct. The cause of the pain is different, but sometimes, and when all else has failed and there's a vessel compressing the nerve, I've had some luck helping patients with that face pain. But in general, when they have Sunct, it's usually something that the neurologists help treat. Whereas with V1, it's a very typical trigeminal neuralgia.
Thank you so much for answering that question. During your presentation, you also mentioned, atypical trigeminal neuralgia, those who have bilateral or may have, burning sensations along with either, the stabbing pain or just the burning pain by itself. And you mentioned medical management as being kind of, one of the best ways to treat that. And you talked about migraine medications or anti-seizure medications. Has there been any studies looking into third generation anti-seizure medications, some of the newer drugs, or you even touched on the CGRP medications. Can you speak to that?
Yeah, so full disclosure, I'm not a neurologist, and I'll probably, I'll defer to the neurologist on the call, on the sessions later today. But it's been the issue with first, second, and third generation seizure meds is that their mechanism of action is very similar, right? They're trying to stop electrical activity, but the side effect profile could change a little bit with these drugs. And so it's more of a, sometimes patients try to have gone on one or the other just to help them with the side effects, because side effects can affect one's quality of life. I mean, one of the things I do in my clinic is I have people do what's called a tandem gait. People jokingly call it the drunk test or the tightrope test. And if you're on a lot of these meds, they cannot do that. And so that's one of the things I look for to assess. Maybe when I see that, I say you might want to try another medication, or there may be time to consider surgery. Even with that being said, the third generation, in my experience, still hasn't really gotten rid of a lot of the side effects. It may mitigate some of them, but there's still a lot of overlap in that. Now, what I was impressed about the CGRP is that CGRP is basically a molecule basically based on calcium. And there's a lot of that molecule or receptors actually in the trigeminal ganglion. And so, especially with patients who might have had more atypical migraines, I've seen some relief. And I'll never forget, I had a patient who had a rhizotomy and actually developed atypical facial pain, and it just did it did the trick. And I wish I had enough patients to do a study, but I'd be willing to bet that there's 10 to 20% of those patients could, with atypical pain, get relief.
Wow, thank you so much. And thank you for sharing kind of your experience there.
Yeah.
Here's another question. They ask about when the glossopharyngeal nerve is compressed by an artery, and the patient also has kind of vagal symptoms, so syncope, irregular heartbeat. Would you recommend decompressing the nerves, 9th, 10th, or 11th?
Well, I mean, so it's really interesting. I've seen case reports of people having the vagus symptoms improved after a decompression. It's not enough for me to tell patients the surgery will address that. If I were to do decompression of the glossopharyngeal in that patient, the primary objective would be to get rid of that pain for them. And if there's improvement in the vagal symptoms, I tell people it's all bonus points, but I would still highly encourage patients to get seen and worked up with their local primary care doc and cardiac or cardiologist. But generally, when you're decompressing the nerve, we decompress it off the 10th as well as the 9th every time. I mean, I do. So that question would be addressed for that patient.
Thank you. Here's another question from the audience, Amy Myers here. She's asking, what is the difference between, trigeminal neuralgia in the V1 branch or ophthalmic branch and migraine? Like, how do you make that differential diagnosis?
Yeah, so sometimes in general, migraines, a lot of them have auras. So if they have an aura and then the face pain happens, that can be a clue that it's a migraine. And then sometimes what happens is a lot of patients get seen by neurologists before and they get put on migraine meds. And if that doesn't work, then usually those are the two clues I look for to try to differentiate in figuring out migraines versus V1-TN. And again, the V1-TN usually has very characteristic pain symptoms. It's sharp stabbing, electrical, and migraines aren't always like that.
Thank you. Here's another question. Is a short-lasting, sharp stabbing pain in the eye a symptom of neuralgia or some type of neuropathic pain?
So the answer, unfortunately with that, I apologize for saying this, is yes and yes. It could be either. Oftentimes, as I said before, because trigeminal neuralgia is a clinical diagnosis, it really means that there's probably encompasses a whole different group of pathologies or pathologic processes. Sometimes when people have deep eye pain, I worry about things like SUNCT in those patients. And that's why I think it's so important to have a multidisciplinary team. And I ask my neurologist to assess. And sometimes it's not. And I mean, you can have you can have pain right around the eye and be V1, and the MVDs have worked beautifully for those patients.
Thank you. Here's a question from Aline Brokaw. She's asking, can you speak to the National Institutes of Health, Neurological Disorders and Stroke diagnostic criteria that classifies continuous, often burning, one-sided pain of the trigeminal nerve? Is it atypical trigeminal neuralgia? I guess she's asking kind of the differences between the different classifications.
Yeah, I mean, so that kind of underlies a bigger process. So there's something called TN1, TN2. I like atypical and typical. And then there's these other classifications that the NIH makes. And what I tell people is, sometimes I tell my patients, don't get really, if it were my sister, I tell people not to get too caught up in all these categories. You got to go back to the two questions. What's the cause of my pain and how can you alleviate my pain? Right? That's what we want. We want to make your quality of life better. And to me, one of the biggest differentiating points is if you have the atypical pain, which is the burning, constant aching pain, which is what I think she's referring to, it's a very different path that we go down in recommending. I mean, the path of treatment recommendations we make is very different than the typical. And so even my functional neurosurgeons, they help doing that. They say, well, okay, if it's burning, aching, I might have something that I can do to offer.
Thank you. Thank you for sharing that. And during your presentation, you also touched on anesthesia dolorosa as a, after certain procedures, as a complication of that. One person is asking, how often do patients end up with anesthesia dolorosa after, having an MVD? How common is that?
Oh, so with an MVD, I have to say it's super rare. I probably have not seen anesthesia dolorosa happen just after a pure MVD. In some of the MVDs, though, when we see no compression, I sometimes offer something called the neurolysis, which is splitting of the nerve fibers. We've also, and just not myself, only some people have offered what we call intraop glycerin. We inject a little bit of glycerin in the operating room. And others actually section or cut a part of the trigeminal nerve in those patients. And when you do manipulations of any sort, you risk anesthesia dolorosa. Now, with the neurolysis, I would say it's exceedingly rare. I don't think I've seen much, but I'm humbled by my patients hear me say this every day, but I am humbled by God every day of my life. And it could be that I've done a neurolysis in a patient and they have it. And I don't want to by any means suggest that it's a never event, but I've seen it actually more commonly after rhizotomies and radiosurgery, the gamma knife, if especially after a second session of radiation, or in some people the nerve doesn't like it. The other place I've seen that is after some sort of dental procedure or plastic surgery, and they have to cut some portions of the trigeminal nerve with some of the facial plastics, and the nerve doesn't heal right. So the answer is, I apologize, long answer. Almost, it's rare for anesthesia dolorosa to happen after an MVD.
Thank you. And I appreciate you touching on kind of the other procedures and the incidence rate and what you see with those for people who experience anesthesia dolorosa.
Yeah.
Another question about geniculate neuralgia, and can it start with kind of a short stabbing pain and then over time, or even during an episode of the sharp stabbing pain, kind of develop into a lingering pain that can last a longer period of time after having that?
Yeah, so the nuance to this geniculate neuralgia is, as I said before, geniculate neuralgia, the surgery for geniculate neuralgia is to cut the nerve to make you feel better. It's essentially cutting off the innervation. You're taking the light bulb out of that room, or cutting the wire to that room. And so the answer is twofold. One, in terms of pain relief, I used to only offer it for sharp stabbing pain. But there's actually cases and reports that people with burning pain or more atypical pain deep in the ear have had relief from the surgery, which makes sense because you're cutting the nerve to it. And so even if it turns into the lingering pain and it's really affecting one's quality of life, it's not unreasonable to get a medical advice from a neurosurgeon to ask if he or she thinks it can help them. But the second point is, we don't really know what geniculate neuralgia is. Geniculate neuralgia is simply a description. It's sharp stabbing pain in the ear. But I think that definition will probably widen over the years to just ascribe it to describe a pain in a location and not be as fixated on character.
Oh, thank you. That's very interesting. Here's another question. I think there may have been, when you were talking about kind of multiple sclerosis or other systemic conditions that can be kind of the underlying cause of different neuropathic facial pain conditions, there may have been some misunderstanding, and I would like to get clarification here. Someone asked if you mentioned that patients can progress to develop MS. Could you expand on that? But I think you were saying MS can be the underlying cause. Would you mind speaking to that, please?
Yeah, I mean, MS can can happen at any point in someone's life. And so as we try treatments for patients, they can develop MS, not because of the treatments, but that we may figure out that ultimately it was the cause of their face pain. I remember a case that I once saw. It was when I was talking to the neurologist. This person had developed horrible vertigo, and she was a young female, and they did the $1 million workup on her. And every year she got blood work also to rule out autoimmune disease. Negative, negative, negative. The vertigo was so bad that she even stopped driving. And then 5 years into it, on their 5th blood test, the titers came back positive, and they figured out that she had lupus. And then when they started aggressive treatment for her lupus, the vertigos got a lot better. It didn't go away completely, but it got better. And that was one of those lessons that I learned, that even with trigeminal neuralgia, I think with autoimmune conditions. Now, this is me just talking about experience. I have to say the data is not as matured on this, but my belief is that maybe with some of these autoimmune conditions like lupus, patients can have atypical or typical pain that manifests and is and it won't be till 3 or 4 years from now that they can feel better. And that's why when I counsel my patients, we're doing the surgery to help them for pain relief, but we still need to always be cognizant that other causes for the pain could come up. Now, MS is known to be associated with trigeminal neuralgia, and I've seen some patients who've come with typical trigeminal neuralgia pain. We've done some treatments for them to help them, like a rhizotomy, and later they developed some of the plaques, and it was clear that that was probably the cause. But I tell those patients, even if you had MS, a rhizotomy would have been a good treatment regardless. And so, again, I always just say you have to be on the lookout for causes for the face pain, because this trigeminal neuralgia, geniculate neuralgia, is a clinical diagnosis, which really means you have to have routine checkups.
So when you're speaking to the routine checkups, is there a certain time frame that you recommend that patients have either repeat MRIs or follow-ups with their neurologist, neurosurgeon? Is there any standard of care or treatment there that patients should follow?
That's a tough one. I don't know if the standard of care, I mean, it's variable amongst most people. I usually like to say most people get a checkup every year. They see their PCP or primary care doc, and once in a while, if they talk with their primary care docs, time is an incredibly important variable. If the character of the pain changes, or if the distribution of the pain changes since their last visit, that might suggest further workup, maybe imaging, more blood tests, something. Whereas if it's something that's been stable and unchanged, maybe the primary care doc would opt to just continue to observe as long as the pain is tolerable or doesn't affect one's quality of life. But I think that this is a field that's a little hard, because we don't know the entity we're going after. And so trying to determine the frequency of any test or visit is hard. But in general, I think, and I should do this better, but I seeing my primary care doc every year is a good thing to do.
Yes, I think that's something we all struggle with at certain times. So we have about 2 minutes left, so this will have to be our final question. And I've seen several people ask about, with differentiating between different diagnoses, who should they see, or how do they determine whether it's atypical facial pain or trigeminal neuropathy or a TMD, temporomandibular joint disorder? Like, how, who is making that diagnosis, and how do you come to that decision?
I mean, most patients that I've seen have gone through their primary care doctors and are sent to me, or their primary care doctors send them to neurologists. Those are the two most common groups of people. And they have made the diagnosis to send the patients to me. And so I think that those have been the best. For people with TMJD, or the temporomandibular joints, I've seen oral surgeons and dentists send the patients to me. So if I were to just look at the 3 most common referral sources for types of doctors, the primary care doc, the neurologist, and the oral surgeons have been the ones to make the diagnosis. So I think those are the doctors that have the best chance of helping you and making the diagnosis. Now, I've always heard, I mean, the thing is, it's a rare disease I mentioned, and not every doctor has been able to make that diagnosis. And some patients have read about it and made the diagnosis and come to me. And I think the internet is the fourth doctor now. And who knows, ChatGPT may have an MD after them after a while. I don't know. But
technology taking us in unique places.
But I've been impressed at how much you can find on the internet, and patients can do that. And I think many of us on this conference today and are dedicated to you, and we've put out content on the internet so that we hope that we can help answer questions for you. And listen, I've seen patients who've come with atypical facial pain, and I don't have that. And I don't generally have a lot to offer, but that's why when in my department, for example, we try to do something comprehensive. And so the whole point is, I think as you go to centers that have neurologists also taking care of facial pain, I'm digressing a little bit from the first question.
That's okay.
It's just not us being able to say, no, we can't help you. At least we want to help everyone. And so that's why we have great neurologists. I'm really excited about our functional neurosurgeons, who I think are really pushing the envelope for people with the atypical pains. And so that's, but yeah, I think getting back to your question, neurologists, primary care docs, and sometimes some of the dentists / oral surgeons have done that.
Yes, well, thank you, Dr. Lim, for your incredible presentation today and for taking time to answer questions, as well as Sanford's partnership with the Facial Pain Association. We are grateful for all that you do.